In the Western world, currently about 1 in 3 people will have cataract or lens surgery in their lifetime, and this percentage is rapidly rising as people undergo surgery earlier to have an active lifestyle, or the procedure is performed as refractive surgery. In 1967, Anton Banco and Charles Kellman obtained a US patent for ultrasonic phacoemulsification and heralded the revolution of small incision cataract surgery. Ultrasound emulsification replaced the previous large incision extracapsular procedure. We are now at the dawn of the next revolution, with phaco being replaced by image-guided ultra-fast femtosecond lasers. This video demonstrates why femtosecond lasers will change cataract and lens surgery. Patients have always thought that cataract surgery is performed by the surgeon using a laser, and it remains a surprise that ultrasound is still being used after 44 years. With a skilled surgeon, perioperative complications with ultrasound phaco are of the order of 1 in 1,000. So why change? What is the point in developing and investing in very expensive laser technology to create a nice, aesthetically pleasing capsular excess? The answer is the femtosecond laser can do much, much more, and is creating an entirely new way of thinking. Ultra-fast femtosecond lasers have pulse durations of a few hundred femtoseconds or less, and deliver very high peak powers without shock waves or thermal side effects. A 100 femtosecond laser pulse with the same peak power as a 100 nanosecond laser pulse has 1,000,000 times less energy. By precision focus of the laser beam, energy can be delivered to about 1 cubic micron. This has been incredibly successful in LASIK and corneal transplant surgery. Since femtosecond lasers can generate pulses with megahertz frequency, it is not possible to perform standard eye tracking, and docking of the eye to the laser system is required. Flattening of the cornea induces distortions, so corneal docking with applanation is avoided. A laser system curved interface is used by LensX and Technolar's Perfect Vision. LensAR uses a scleral low-pressure suction ring without applanation. Optomedica has an innovative liquid optics interface. A fluid bath over the cornea significantly neutralizes anterior corneal curvature and avoids the optical distortions which go with corneal flattening. A femtosecond laser beam has some chromatic dispersion, as femtosecond pulses are not monochromatic. In order to minimize any error between imaging and laser delivery, the OCT scanner and femtosecond laser have to both be coincident with similar wavelength. Then what is intended is achieved. The OCT imaging and guidance are critical to the success of the procedure. Imaging of the whole anterior segment is performed, and scanning algorithms are employed to place laser pulses to exact defined positions. The procedure begins with planning treatment using the OCT imaging. At this stage, the anterior and posterior curvature of the lens are imaged, and the equatorial plane of the lens is mapped. This likely allows better estimation of the final lens implant position, as the anterior and posterior leaves of the capsule come together around the lens implant post-op. This has been the holy grail of biometry, as final lens position has been the missing factor, accounting for 60% of biometry unpredictability. A second improvement in biometry calculation is having the lens implant perfectly centered over the entrance pupil and not flopping around within the capsular bag. The femtosecond laser is used to deliver pulses to the lens, and gas breaks up the lens itself. This allows irrigation aspiration of the lens remnants when the lens is relatively soft, or speeds up phacoemulsifier lens removal. The femtosecond laser can be rotationally registered in the same way as excimer laser users are familiar with. Features of anatomy can be used, and the femtosecond laser can be applied to the lens capsule in an asymmetric way to ensure toric alignment. The capsular excess is created by the femtosecond laser by using multiple pulses, creating microvoids in the lens capsule. With near-perfect sizing and position, this allows for symmetric forces to grip an intraocular lens, reducing tip and tilt and improving centration. This lens design has centration and rotational registration using the Optomedica Femtosecond laser. The laser system is used to create a primary capsulotomy of 4.8 mm diameter. Then 4 small ovoid femtotomies are created, which are rotationally aligned. There are no haptics, but there are 4 lugs which project slightly forward. Other lenses are being patented and designed for capsule fixation, such as Marie Tassignon's capsule in the lens implant manufactured by Morcha. The phaco-incision and any side ports are easily performed with the femtosecond laser with self-sealing design geometries. In addition, intrastromal astigmatic keratotomy cylinders can be performed, as are currently delivered with corneal refractive femtosecond lasers. This technology is revolutionizing cataract and lens surgery, changing biometry for the lens implant and what is required of the cataract procedure. It was in 1993 that I presented picosecond cataract surgery at ASCRS, which had potential but limitations. Now, 18 years later, femtosecond laser systems have finally arrived.